Hello. So today I wanted to talk about Xanopril and amlodipine. These are two different medications, very key medications for blood pressure, for the high blood pressure that's very common everywhere these days. But these are completely different. So the Xanopril has the path of the ACE inhibitor. These are both different classes, right? So ACE inhibitor has other companions that have different paths, but an ACE inhibitor binds onto the ACE enzyme, like the name it suggests, but it's what turns angiotensin 1 into 2. This enzyme, ACE enzyme. And angiotensin 2 is a vasoconstrictor, so it's stopping that before it gets to that. And it makes the vessels tight, and the blood pressure would increase. So, stopping the RAS system from working, so that the RAS is renin, angiotensin, aldosterone system. And the three things that lisinopril really does is it stops the angiotensin enzyme from working, making vasoconstriction, but also works on aldosterone, which which lets you let go of water. So no aldosterone means you aldosterone means you hold on to sodium and water, but you know make sure that doesn't happen. You're holding less water. That also has effect on blood pressure. And thirdly, so and that's also in the kidneys. Um, Thirdly, they make bradykinin. So bradykinin is the Xenopro makes more bradykinin. Bradykinin makes endothelial cells release nitric oxide, which also can lower the blood pressure. So even if you hum, you can create nitric oxide to a certain extent and lower blood pressure. But that's another talk. Maybe I'll talk about that another time. Nitric oxide. I think it was chemical of the year, maybe in the 90s, I think, or something in one of these years. But nitric oxide is very effective. So the three things, I should write that down. Three things that ACE ACE inhibitor does is stop angiotensin, angiotensin, angiotensin to stop bradykinin, no, stop aldosterone from holding water. Aldo from holding water. And three, increase bradykinin. And the important part is nitric oxide. More make nitric oxide. And these are how it lowers blood pressure. But the zinc carboxyl groups, so you can see carboxyl groups right here, are how the lisinopril can target the ACE. That's how it gets. This is how it kind of it mimics a peptide. There's a word for that. Peptide mimetic, if I'm not wrong. It pretends to be angiotensin 1, and it gets you the ACE enzyme. So it's a little bit of a ninja, a little bit of an imposter. But then we have amlodipine. So amlodipine stops calcium from entering smooth muscle vessels, because in the class of calcium channel blockers, there are three different classes of how L calcium channels are worked with. But to start with, this is a dihydropyridine ring, and it has a lot of substituents usually that can make it last a lot longer in the body. So you can use it once a day and it's fine. But what calcium channel blocker, and all three these do is a channel, right? Seeing the circle. The channel needs calcium to make contractions, so it works as a different system from RAS. ACE inhibitor uses RAS, so renin, angiotensin, aldosterone, but calcium channel blockers use the idea of how calcium calmodulin to myosin activation and the active myosin bridge makes a contraction. That's the big difference. So RAS versus calcium calmodulin myosin. Those three are the keywords for each of these: the renin, angiotensin, aldosterone, and calcium calmodulin myosin. And these contractions increase blood pressure. So, amlodipine in the dihydropyridine class, it works more on the smooth muscle vessels, and these are L-calcium channels that are more inactive, resting. But this is different from the classes of verapamil of the phenylalkylamine class. And all these examples, verapamil is the best example of phenylalkylamine right here. So this is a ring, it's more rigid, and this works more in the heart. It's a rigid structure with a ring and alkylamine side chains. They have more of a preference for open and inactivated states of the channel, and these are more common in the muscle of the heart and the nodes, which is the very important one. So it has less influence on the blood pressure and more on electrical impulses of the SA node. So it's a negative impact. So you think of epinephrine would raise the amount, but this is opposite. It's negative. And the chronotropic, I think it's believed, negative. It's negative, so it slows that down. And you do use this in some conditions where you do want to influence the heart, and usually it's about rhythm or pace of the heart. So the supraventricular tachycardia and atrial fibrillation. This is when you have messed up rhythm of the heart in the nodes. But usually you want to leave your heart rate alone. But that's the big key difference between verapamil and amlodipine. Amlodipine is more in the smooth muscle, and verapamil is more for the heart. And they both work on the same kind of channels, or L channels, but they work completely different in location and what they affect. And otherwise, we have a third class of the calcium channel blockers. There's benzodiazepines, and it's right here. It has a nitrogen and sulfur, as you can see. And these are more of like a balance of these two. It's moderate lipid loving and moderate in rigidity. So it works a bit in the heart and a bit in the smooth muscle. And benzodiazepines is this name structure, and this structure is a phenylalkylamine. Right? And sorry about the noise. But that's the main difference in location of how these work. But these three work on L channels, right? This is in the smooth muscle vessels. This is in the heart. This is a balance of the two. And this works on the ACE inhibitor. And you can think of this more of the kidneys. But this smooth muscle and heart, or balance and heart, this is the kidneys. And in renin and angiotensin and aldosterone are the three ways. So angiotensin, aldosterone, which is water related, and nitric oxide, which is vessel opening. And that's it for today. Thank you.